Afternoon, everybody. Good to see you all on this Wednesday. I'll give everybody a moment to get connected. We're so happy that you joined us. We have an exciting discussion today. Before we get started, I'm going to go over some housekeeping with you all. My name is Anissa Mitchell and I'm with PMD Alliance. I'm going to invite you all to open up your chat box if you're not familiar. I know all of you are probably pros at this, but I'm not going to make too many assumptions. So if this might be your first time on one of our meetings, you can just hover at the bottom of your screen and you'll see a little box that says chat. If you would click that open, that is how we're going to communicate today. I invite you to put your questions there as we go today. When you have questions for our speaker, Dr. Friedman, we will collect those. I would love to get a shout out to where everyone is joining us from. It's lovely to see where all the people come in to our programs from. We already see someone sharing there from Charlottesville, Virginia, and Ventura, California. So good to have you all. The other thing that I want to point out is, I don't know if you're seeing this right now, but at the bottom of your screen, we do have some closed captioning. So if you like that feature and you want to be able to read what is said, it does a pretty good job of keeping up with us. You can leave that, or you can click on the closed captioning. You can hide your subtitles. So if your chat box is open like mine is, you might have to scroll over to where the three dots are that says more. The little box will pop up and you can just click hide subtitles. So you have the option to leave them or to hide them. So I want to get started. Today we're going to be having a discussion about impulse control disorders. And I want to introduce our speaker, Dr. Joseph Friedman. He is the chief of Butler Hospital's Movement Disorders Program. He's also a professor and chief of the Division of Movement Disorders in the Department of Neurology at the Warren Alpert Medical School of Brown University. Now, I first learned about Dr. Friedman because I came upon his book, Making the Connection Between Brain and Behavior, Coping with Parkinson's Disease, where he covers psychiatric issues and non-motor issues in Parkinson's, including mood changes such as depression. He talks about cognition. He talks about hallucinations, delusions, and includes compulsive behaviors, which is what we're going to focus on today. So he's going to be covering things such as compulsive gambling, shopping, eating, and even hypersexuality. But he's also going to be covering some lesser known compulsive type behaviors so that we all can become aware of them. So please feel free to chat your questions as you go, because I'm sure there will be people that have many questions. I also want to let you know that we will drop into the chat the name of his book, Making the Connection Between Brain and Behavior. You can get that on Amazon, but he also has a free book that you can get without purchase, and it's online. It's called The Free Guide to Parkinson's Disease. So we will also include that on there, which has some great information for everyone as well. So I'm going to turn this over to Dr. Friedman and just thank you for joining us, and I'm going to let you take over.
Okay, well, thank you. So let me share my screen, put my slides up. And get my slides working. And there we go. Let me get rid of this. So thank you very much for this very kind and generous introduction. And thank you very much for this invitation, of course. It's always a pleasure and an honor to give a talk to people with Parkinson's disease. As I always say, these are true experts since they live with the disease all the time. Either you're a patient or a family member or a friend of somebody with Parkinson's disease. The topic I'm going to talk about today is impulse. They're called impulse control disorders, although I think that's actually a misnomer because the problem is more of compulsivity. People always have the urge to do certain things. They're not taken over by an impulse where all of a sudden, out of the blue, they do something unexpected. And what we've learned over the past many years since we've been using dopamine agonist drugs, that these drugs increase the likelihood that someone is going to develop this problem. So the first thing I thought I should mention is what a dopamine agonist drug is. So chemically, an agonist is a chemical that works like something else. So dopamine agonists are drugs that have the same pharmacological activity as dopamine. The most important drug that we use in treating Parkinson's disease, of course, is levodopa or L-dopa, and people take it in a combined form with carbidopa, and the carbidopa is there to prevent the nausea that you would otherwise experience by taking L-dopa. L-dopa is taken up into the brain and converted to dopamine. So that's how it works, and probably that's why it works better than the dopamine agonists. But the dopamine agonists have a role, and they are frequently used. The drugs currently available in the United States are pramipexole with brand name Mirapex, ropinirole, which has the brand name of Requip, rotigotine, which is the Nupro patch, and there's another drug that we don't use in Parkinson's disease, but could be, called cabergoline. The brand name is Dostinex, and that's used for stopping lactation in postpartum women. These drugs are also used for treating restless leg syndrome, but at much lower doses than we use for Parkinson's disease. And they also are used for treating pituitary adenomas. Those are small tumors of the pituitary gland in the brain, which are benign tumors, but can cause a lot of trouble when they grow. And these drugs, the dopamine agonists, make them shrink so that they don't cause the trouble. Dopamine agonists were introduced probably in the early 1980s, late 1970s. Drugs like bromocriptine, pergolide were widely used, and they were used for really about 15 years before anybody made a connection, actually 20 years before anybody made a connection between these drugs and these particular kind of very peculiar behaviors. So these behaviors are compulsive behaviors where people feel a need to do certain things. Certain of these behaviors are more common than others, and I'll go over those in just a minute. So I mentioned what dopamine agonists are. Now I'll talk about obsessions and compulsions. We all frequently talk about people with an OCD personality, an obsessive compulsive personality. So an obsession is an idea or thought that continually preoccupies or intrudes on a person's mind. That's a dictionary definition. A psychiatric text has defined an obsession as persistent ideas, thoughts, impulses, or images that are experienced as inappropriate or intrusive and that cause distress. The content is often perceived as alien and not under the person's control. So a person may be absorbed by a feeling or an idea that is foreign to them and which is uncomfortable and which they know isn't true, and yet they have to just basically live with this idea. A compulsion is a need to do something. People do something repetitively. You're all familiar with compulsions of people who have to, say, wash their hands because they're phobic about getting germs, or people who have to check things frequently. They have to check that they lock their doors, that they close their windows, that they turned off the range or the oven. And even though they've done it, they have to do it a second time or a third time or even more than that. And so these are behaviors that, if not taken to an extreme, may be quite normal and even exemplary. All of us would like our surgeons, for example, to be compulsive. They have to make sure that they didn't leave anything behind inside your body, that they sealed off all the bleeding blood vessels, that everything is sewn up correctly. But if they have to go back 10 or 15 times to check over the same thing, you would agree that that's not appropriate and that causes more trouble than it solves. An impulse, however, is a sudden, strong, and unreflective urge or desire to act. So somebody says, I just have to buy that thing. They go out and buy it, and then they have buyer's remorse because they didn't really need that. So we have, for whatever reason, taken on the use of the term impulse control disorders for this whole host of disorders that are associated primarily with dopamine agonists. They can be associated with people who just take levodopa, but that's much, much less common. So although we call them ICDs or impulse control disorders, they're really compulsive. They're not impulsive, and they're not associated with anxiety. People just feel a need to do something. People who have primary OCD, that is, people with primary psychiatric disorders, feel very anxious if they're not washing their hands, for example, or if they're not, organizing things into exactly the right position on a desk. If they're not neat freaks, for example, they feel anxious if something is out of place. With compulsive disorders that Parkinson patients get on the drugs, they just feel a need to do something and they feel better doing it. And they don't generally stop to reflect on what the impact of those activities necessarily are going to be. So this was first described in 1994 with an article on punding. Now, punding is a term that I would assume that none of you know, or very few of you know, because very few people in the world knew what this was. Punding was a behavior that was first described in a paper describing this peculiar behavior in amphetamine addicts. So these were people who were drug abusers, typically younger men, who would use large amounts of amphetamine to get high. They weren't people with attention deficit disorders, and they were using it to get high. And people who had used the drug at large doses for long periods of time would have these spells where they did something like take apart an object. They would take apart radios, they would take apart flashlights or lamps and just put them back together, take them apart, put them together, and do this for hours and hours on end, and didn't like to be disturbed. So they were highly focused, doing this one peculiar behavior that had no meaning in particular, but they didn't like being disturbed. And a paper in 1994 described this behavior in a small group of people with Parkinson's disease. So, for example, one of the patients was a bookkeeper, and he would tally figures over and over and over again. So it made no sense because each time he tallied them, they added up to the same thing. This was, of course, in 1994, before everybody used computers for everything. So he would have to enter this into a adding machine. And he would do them over and over and over again. And he would explain that this made absolutely no sense, but he felt compelled to do this over and over again. I had another patient who felt a need to read all the print on a tin can. So when she would be shopping, as soon as she came to the first row of cans, she would stop and she would read all the fine print on the cans. And for a while, this was okay with her family because she would stand there and they would just collect her at the end of their shopping and take her home. But after a while, it became difficult because she wouldn't want to leave because the can was there and there were all these other cans that she also wanted to read. So she couldn't stop this behavior. Another patient who liked to weed, and she couldn't stop weeding, and her compulsion to weed her lawn was so great that she couldn't stop, and she would wet herself when she had to urinate rather than stop the weeding in order to go to the bathroom. So these clearly are very abnormal behaviors, and they didn't bother the patient. The patient didn't say, gee, I'm doing this weird stuff. I can't stop it. It's really crazy. I have to get over it. But the family, of course, would be very upset by this. In the year 2000, so about 6 years later, somebody described for the first time this very rare behavior that people who saw a lot of Parkinson patients would see on rare occasion, which was basically a levodopa addiction. They would collect levodopa and take it to an excess. And even if it caused problems, they would still insist that they needed to take more. When asked about it, they would deny that they were taking it to excess, but they would complain that if they didn't take it, they didn't feel well. And it wasn't feeling poorly in the sense of having off periods like you're all familiar with on-offs. They just felt poorly and the medicine made them feel better. So an example of that was a patient of mine who took this medicine to excess and would start hallucinating and become delusional. And he was certain that his next door neighbor was having parties at night. And he was very upset that he hadn't been invited. And he would knock on the door at 2 or 3 in the morning, complaining that he hadn't been invited to the party. And of course, the neighbor was not having a party. So the neighbor was not too pleased. And this happened a few times. The man got arrested, actually. And yet he would continue to take the medicine to excess. Another patient who had bad Parkinson's disease and developed the syndrome developed another neurological problem, a severe Guillain-Barré syndrome, which made him quadriplegic. He was unable to move his arms or his legs. So he never had on periods, he never had off periods because he didn't have movements. And yet he would crave the drug and insist on being fed the drug basically as often as he could get it, despite the fact that it didn't alter his movements at all. So this syndrome was called hedonic homeostatic dysregulation, based on another paper that used this term to describe this addictive type of behavior. Then in 2002, there were 2 articles that described the connection between gambling and the use of dopamine agonists. So I'm going to give you some examples of actual patients describing these problems, and it'll give you an idea of the spectrum of what you might see. So the ones that are most common are gambling, and I'll have a video interview with that. Another common one, more in men than in women, is hypersexuality, where people become really obsessed with sex to the point where they will be searching the internet for pornography. They'll be demanding sex from their spouse, and they'll be doing this inappropriately where their advances are unwanted. And when they're doing things like the pornography, which were things that they never did before, they might be making unwelcome advances, obviously getting into trouble with their spouse if they start approaching other women. It occasionally affects women, but not nearly as much as men. But there are other behaviors that occur as well. So this one I'm calling completing, which is once a person starts a task, he can't stop. describe what you feel when you have a chore, something that breaks, say, in your house, and you need to fix it?
Basically, if something breaks, I got to do it right away. The doorbell broke, and I did it that there. Then television wasn't working right, and I was up till 1 o'clock in the morning looking for the wires. And it was raining out, and you had to go outside to get to the basement. So at 1 o'clock in the morning, I went outside, down the steps into the rain to get the wire. I went back upstairs again. That wasn't right. I had to go back down again. But by 1:30, the television was working fine and complete the project. But I just could not wait till the next day because it would have bothered me all night.
And you said that he used to be like that, but not nearly as much so. This is sort of an exaggeration of the way his personality was before the Parkinson. Is that right?
Right.
Okay. Thank you very much. So here's a man who once he had a chore, he couldn't stop doing it, despite the fact that he wasn't planning on watching television at 1:30 in the morning, and it was raining outside, and yet he wouldn't feel comfortable going to bed without completing this chore. And this is kind of the opposite to a similar problem that a colleague of mine described, who was actually another movement disorder specialist who saw a patient with Parkinson's whose father had Parkinson's disease. Before this syndrome was described, he reflected on the fact that his father, who had Parkinson's disease, would always be doing some construction around the house, that he was always fixing something, and that whenever my friend visited his parents, there was always something being fixed, although this person never finished what he started. So there are lots of projects, no completions. This man is kind of the opposite, but once he got a hold of a project, he couldn't stop working on it. And people with this will stay up all night and do what needs to be done. The gambling is the one that you probably all have heard of. And the gambling, along with the hypersexuality, may cause lots and lots of problems. So I was an expert witness for a lawsuit in which there was a complaint that the doctors hadn't adequately explained this problem, although the chart would say otherwise, where a man gambled away money that was being used for his wife to start a business, and this ended with a divorce. So this can be very serious. So here is an interview with a man and his adult daughter. The man lived alone. His 2 adult daughters cared for him. They made sure he had enough money, enough food, enough everything. And yet he would weasel money out of relatives, saying that his children were withholding money, they were taking his money, they were using it, and saying very bad things about them, despite the fact that they were really performing rather heroically in trying their best to take care of him. So first of all, I'd like to thank both of you for agreeing to this interview and for allowing me to show it in front of doctors and other health professionals. So first, I'm going to start with your daughter to describe what she went through with this problem with the gambling, okay? And then I'm going to ask you to say a few words too.
My father's had Parkinson's for over 10 years. At the beginning, we were finding that he was spending unnecessary money. It has led to us taking over his finances. He has totally wiped out his life earnings, which was about over $250,000, with visa bills over $25,000 that had to be repaid. Now he's only allowed so much money per week. And with this, as soon as he gets money in his possession, he will spend it on things, like food and everything, but he will also lie and spend it on scratch tickets, which he claims is not a form of gambling. It's just a few tickets. And when asked about his life savings, he will say that he doesn't cry over spilt milk. And just yesterday, he said that he took $25 out of the bank. I asked him what it was for. He told me it was for dry cleaning. When I asked his help, what the $25 was for. Did he pick up dry cleaning? He knew nothing about that. And then my father admitted that he spent the $25 on scratch tickets. So this is just one of the thousands of examples how he continues to lie about how he uses the money that we give him and allow to him.
And he didn't have a gambling problem before the Parkinson's?
Absolutely not. In
Right.
fact, when he used to go to Atlantic City a few times with our mother, he used to get angry when my mother used to play the nickel machines.
Okay.
And then he used to gamble a few games of baseball, but that was like a neighborhood pool but it was never ever as much as bad as this.
Well, thank you. And what's your take on this?
Well, I must admit that once I started with the Myra pills,
Yeah.
my gambling habits became very attractive.
And what do you see? How do you see it now? I mean, your daughter says it's still happening.
I'm not gambling that much money. I do buy a scratch ticket. I do play the lottery when the winnings are like $100 million.
Yeah.
They a lot.
Do you think she's exaggerating?
She's exaggerating.
Yeah. But you did lose all your life savings, right?
It wasn't $250,000.
But it was a lot of
I
money.
had $125,000 in my bank.
But you lost that.
I lost that.
Okay. So that's still a lot of money, I think,
It
right?
is.
Okay.
I'm very sorry I lost that.
Sure.
And
But what about the $25 you spent yesterday?
$25 I spent yesterday. I spent $15. So I had gone into Chubby's shack and I had fish and chips and I had.
No, what about the scratch tickets?
I bought a couple of scratch tickets.
So you're still, but you don't see that as a problem.
I don't see that as a problem.
Okay. Thank you very much. So this is a typical sort of thing. The people start gambling and they don't see it themselves as a problem. They minimize the problem and they basically behave like addicts. That's why I brought up the other problem about the hedonistic homeostatic dysregulation, which is basically L-DOPA addiction, that people who develop these problems generally don't see them as problems. They're unable to step back and try to see it objectively that this would cause difficulties for their family, and they just continue to do it. It's an irresistible need that they have to do these things. And some of them can be very, very unusual, which we'll get to, but gambling is the most common. Men do it and women do it. They do different kinds of gambling. Around here, there are casinos and people like to use the slot machines, but they could gamble on anything. And the minimization is just like an addict's minimalization. Well, I don't use so much of this drug. I only take it once in a while. I only use it when I need it. He had lost his entire life savings, and yet it was his daughter exaggerating that it wasn't such a big deal. Obviously, it was a very big deal. And you could imagine how much grief this causes. And because it reflects an addictive type of problem, that patients who have it will not necessarily talk about it with their doctor. So when a doctor puts a patient on a dopamine agonist, it's important at each visit to ask about these sorts of behaviors. But when the patient comes alone to the doctor's appointment, they frequently won't mention it because they don't want anybody to interfere with it. So it's very important at the beginning of using one of these drugs that the family be involved. So I always ask the patient, if the patient's alone, that when they're starting the drug, they need to mention to their spouse or their child or friend or significant other, whatever, that these drugs sometimes cause this problem. Patients almost always find this amusing, the idea that their personality could change so dramatically. So I think they do, and I encourage them to bring a family member. And if I think a problem like this is going on, then I will call a family member if the person doesn't come. Usually it doesn't begin right away. Most patients, at least in my experience, have some kind of dose threshold after which it develops. So at the beginning, there's no problem. So I don't usually see this develop until patients have been on the drug for some period of time, months or years even, before it starts. So I mentioned punding, which was this sort of senseless repetition of a simple act. So in this case, the person is picking threads from her pants. Sometimes patients will organize their clothes in a drawer and then just spend the whole day doing it, or they may.
How much of the day will you spend doing that? Picking on your trousers?
It depends on what I have to do. If I have other work to do,
You mean other work like cleaning your stove?
yeah.
You like to clean your stove a lot
I clean the house and bake.
and bake.
I love to bake.
Okay. But when you clean the stove, you're a hard person to stop, aren't you?
Yes,
You like to keep cleaning the stove.
I like to get it all clean.
And when you clean the stove, how long might you spend cleaning the stove?
Depends how dirty it is.
Well, say it's not too dirty. How long might you spend?
I don't know.
An hour cleaning the stove. Can I make this videotape of you to show to other people? So I can include you? Okay. And how long might you spend pulling the lint off your trousers?
Maybe an hour and a half.
You might spend an hour and a half cleaning the lint off your trousers. Does that bother you in any way? Okay.
No.
So you enjoy this sensation of doing that?
Yes,
Do you look forward to putting on your trousers so that you can pull the lint off?
no,
Do you get upset if you don't have trousers on?
no.
Okay. And I'll just point out for people watching this video that there is, in fact, pilling of the trousers, that she's not hallucinating things. She actually pulls little things off the trousers that are bothering her.
So this is a more difficult one to assess because overeating is so common in our society. It's hard, most people who are overweight and overeat don't have Parkinson's disease and don't take these drugs. But here's a typical kind of example. This is fairly common.
Thank you for allowing me to make this video, which is basically you're talking about your weight. You mentioned to me that you gained about 8 pounds since I saw you last a few months ago. What's that due to?
I seem to be eating more in the evening, and I'm not really hungry at the time. I just have an urge to have more food.
And did you ever have a problem like this before?
I eat more in the evening generally, but not to the extent that I have recently.
So your weight had been pretty stable for many, many years?
Yes, it was around 185.
Okay, and now you told me you're up to 193.
Yes.
And is there any particular food that you have a craving for, or you just feel a need to put something in your stomach?
I have a predilection for sweets.
You do.
I do. That's been ongoing.
And is that, did you used to have a predilection for sweets?
I did, but I didn't eat as much as I have been recently.
Okay. Any particular kind of sweets?
Chocolate chip cookies are
Okay. Sounds good to
pretty
me.
tempting.
Okay.
Well,
So that's a common sort of story. For whatever reason, Parkinson patients like to eat sweets. But one of my colleagues took care of a patient who gained 20 pounds eating one form of apple, Braeburn apples. She gained 20 pounds eating Braeburn apples. And when she stopped the medicine, she stopped eating the apples. So it can be a highly focused compulsive need, which is very difficult to understand how our brains work in such a way. These types of behaviors occur in somewhere between 10 and 14% of patients who take the drugs. They are more likely to occur in people who had a history of a similar type of behavior. So somebody who had a gambling problem before and then is put on a dopamine agonist is much more likely to have a recurrence of their gambling problem than a person who never gambled before. But oftentimes these problems come out of the blue. So gambling is the most common. Among men, the second most common is sexual preoccupation, often with sexual activity. Compulsive shopping, although I had a patient who had compulsive comparative shopping. She actually could not buy the thing that she needed to buy because she felt a need to get it at the best possible price. And this was before cell phones, so that she didn't have any app that would tell her what the cheapest price was for any sort of thing that she was looking for. Hobbyism is the term we use for people who just feel compelled to do a hobby. Sometimes it's things like fixing your house, doing little construction projects, but more often things like playing computer games and basically being unable to stop, so that you don't like having friends over, you don't like visiting people, you don't like going to bed at night. There are people who overspend. There are people who collect things. I had a patient who spent his free time collecting uranium glass. So that's glass that had uranium in it, which glows in the dark. It's not dangerous, so there's no increased cancer risk, but it was an unusual sort of collecting thing. And in some places they describe walkabout, where patients like to walk about, like, leave their home and just walk about for long periods of time because they just feel constrained when they're at home. And some of these behaviors can be, as I said, as minute or as focused as eating one type of apple. I had a patient who made cherry pies. He made one cherry pie every night, but he didn't eat cherry pies so that he would have to give them away, and yet he felt compelled to do that. They can be bizarre, like collecting unusual things. I had a patient who collected broken lawnmowers, and as you could imagine, his wife was not keen on their lawn being littered with a large number of broken lawnmowers. Recently, a patient of mine who I started on a dopamine agonist and asked about, would ask every visit about these behaviors, came back at one office visit and said, "You know how you asked me about these compulsive behaviors?" She said, "Since I was here last time, I noticed that before I go to work in the morning, I have to change my clothes 2 or 3 times, that I didn't used to do anything like that. I would just get dressed and I would go to work and there was no problem. And when I pick out my clothes in the morning, they're perfectly fine, but I feel a need to change them 2 or 3 times before I go to work." And by lowering her dopamine agonist, we stop that behavior. In the punding, which I mentioned before, I started off by telling you about a fellow who couldn't stop tallying figures, or the woman who was reading printing on cans of food, another person who couldn't stop trimming her hedge until she had no hedge left. I've had a few patients who spent time polishing pennies. The woman who weeded the lawn would spend her time when she was indoors pulling threads from her carpet. And recently, one of my patients had difficulties, his family had difficulties in keeping him from clipping his toenails. He needed to clip his toenails to the point where actually his toes started to bleed. And we stopped that, of course, with changing his medications. Hobbyism, I mentioned before, and fishing is one. I had a patient who fished a lot. He was an avid fisherman his whole life. But when we stopped his dopamine agonist for other reasons, he told me that his fishing had toned down, that he was fishing now, but not nearly as much as he used to fish. He was no longer fishing in dangerous situations, like fishing off the rocks during the winter or going out on a boat during the winter, by himself to fish. This last one, hopefully I won't see again. Actually, I've had two patients who started using cocaine. One was a man in his 70s or around age 70 who started using cocaine, and then he would go to bars and pick fights despite the fact that he had Parkinson's disease. So people can get into a lot of trouble. I mentioned risk factors, typically history of doing similar compulsive types of behaviors, particularly pathological gambling, people with a history of substance abuse, men and younger age patients are more likely to develop this problem, but it could develop in anybody. And it, is often quite benign. When I try to explain this to people, it's as if somebody takes up a new hobby that they didn't know that they would enjoy knitting, and knitting suddenly looks attractive to them, or watercolor painting, and then they start doing this thing and they find it very rewarding in some way, and they do it more and more and more until it becomes a major problem for them. The second one was about the sexual preoccupation. I mentioned that patients who have these problems generally don't want them to stop, that they behave like addicts, but not everybody. So this man with a 10-year history of Parkinson's disease found it very uncomfortable that he was sexually preoccupied. He thought that this was going to cause him problems because the need for extramarital sex was becoming overwhelming, and he really did not want this to occur, and reported this to me so that I was able to reduce his medicine before it caused trouble. But in other cases, of course, it does cause trouble. And I told you about the gambling. So the important thing to know, number one, is if this problem occurs, it's not on account of moral turpitude. It's not that this person has become a deviant in some way. It's that their personality, which of course is formed in the brain as a result of brain connections and brain physiology, that their physiology has been altered by the medications that we doctors give them, and so that their responsibility for their actions is somewhat diminished. Not that they have no responsibility, but that it's somewhat diminished, and these behaviors need to be understood in the context of a drug side effect. And they can be fixed, but of course they can't be fixed till they're recognized. So number one, the neurologist or whoever prescribes the medication needs to warn the patient and people who know the patient that these problems may occur. The neurologist should ask the patient to discuss this potential problem with the spouse or caregiver or whoever they have contact with before starting the drug, so that the patient, the caregiver, will be aware if this behavior develops that's related to the drug. And if possible, this intimate contact person should accompany the patient to the doctor visits. And when the patient describes these problems, the doctor should always assume the likelihood that the patient will minimize the problem. Oh, you're having a gambling problem? Well, yeah, but it's well controlled now. Well, it may be, but it may not be. And it's important for the doctor to try to get a measure of this from someone other than the patient himself or herself. So we don't understand why these occur. There are lots of theories about brain function, how it works, and how these drugs change brain function so that people are develop these sorts of addictive types of behaviors. You're probably aware that dopamine is involved in a lot of brain functions, and is thought to be involved in reward behavior. You do something and you feel a reward for having done something, and they're involved in addictive behaviors, as you could see with these, and we need to be very careful. And we don't know potentially all the side effects that people may be having even now that have not yet been identified with the drugs that we use. After all, who would think that by giving a person a drug, they're going to start gambling? It was an unexpected connection, but turns out to be very real. I will stop there and be happy to answer questions. I hope I didn't run too long.
Okay, it took me a second to get to my unmute. We actually have a lot of really good questions, so I'll try to cover all of these, and maybe some of them I can combine. So I want to go back because you talked about some risk factors just a couple slides back, and you mentioned obsessive compulsive behavior of somebody who had that maybe prior to Parkinson's could be at a greater risk. So this person had written in that 3 months before their loved one's diagnosis with Parkinson's, his sexual addiction was revealed. He does have obsessive compulsive personality disorder. And so that was with, prior to Parkinson's. And they want to know, without the meds that influence these behaviors, is this a trait that would worsen, or is it a precursor to Parkinson's? Meaning, is this something that could have been, maybe, I think they're maybe asking, is this a prodromal?
Well, we don't think that this is related directly to Parkinson's disease. We think this is an effect of these drugs in somebody with Parkinson's disease, and that these have been identified in people who take these drugs who don't have Parkinson's disease. So it's related to the drug, and it may be related to the dose of the drug. But people who have a history of this type of behavior are at greater risk for developing this behavior if they're treated with dopamine agonists. We don't think their risk is significantly increased if they're treated with levodopa or amantadine or other drugs than the dopamine agonists. So pramipexole, Mirapex, rotigotine, which is Nupro, and ropinirole, which is Requip, are the drugs that for somebody like that, I would try to avoid.
Someone had asked if you could repeat again the percentage of people with Parkinson's that are on dopamine agonists, what their risks are,
So,
or that many that are impacted by it.
I don't know what percentage of Parkinson's patients are treated with dopamine agonists. That would depend on the individual doctor and the nature of their population. But about 10 to 14% of people who take dopamine agonists for the treatment of Parkinson's disease will develop one or more of these behaviors. And I didn't mention that having one behavior doesn't keep you from having more than one. So the woman who was punding also cleaned her oven a lot. So she was doing two. But people who gamble pathologically may also, eat apples excessively and chocolate chip cookies at night. So you can have more than one behavior. The major risk factors are having a problem like that prior to developing Parkinson's disease, and then or substance abuse problem, and young men, for whatever reason, also seem to be at greater risk.
So I've had several questions in relationship to the medication. So one person wanted to know, other than the dopamine agonist, can this happen just in Parkinson's alone, or is it only medication related? And does it also happen just with increases of carbidopa, levodopa without the dopamine agonist?
Yeah, it can happen with carbidopa, levodopa alone. I don't know how often it occurs in untreated Parkinson's disease patients. I haven't seen that. It is thought that people on carbidopa, levodopa alone and untreated patients probably have about the same incidence of these types of problems as the general population. I mean, I don't know about as specific as just eating Braeburn apples, but there are unusual behaviors that occur in normal people.
And one person had written in that they stopped their dopamine agonist 4 years ago, but still have moderate impulse control disorder.
Yeah, that certainly does occur, and I can't explain that. In most of the patients, at least who I see, that when we lower the drug or discontinue it, the problem generally goes away, but certainly not in everybody. And then you have to approach it as you would treat that similar problem in somebody who didn't have Parkinson's disease necessarily. You know, these obsessive compulsive disorders, you know, are a category of psychiatric problem that are described in people who don't have Parkinson's disease. And there are treatments for them. There are medication treatments, there are behavioral treatments, and I think they're relatively effective.
Right. So you mentioned, things like punding and hobbyism and other compulsive behaviors. So what about hoarding? So someone had asked about that, how to talk to someone who's hoarding. They didn't say what they were hoarding, and point out that they're not acting rational without getting them insulted personally. And others had written in about how do you address this with someone who may not want to stop the behavior. And I think you kind of mentioned that also.
Well, that is a significantly and very interesting question. If a person is engaging in behaviors that aren't harmful to themselves or to other people, should you interfere? You know, if somebody collects, hoarders, there are TV shows, real, reality TV showing hoarders, and their houses are can be really incredible. But if it doesn't cause a problem, is it a problem? Usually there are other people who are affected by this. So a person who hoards, if they live alone and their house becomes, a mess, looks like a warehouse, that's up to them as long as it's not a fire hazard. But if they share a house with other people who are not so pleased with what they're doing, then it's causing a problem for other people. Just like if a person gambles and they're no longer working and they're spending their spouses or their children's money, that's a problem for other people, even though they're not physically harming anybody. And that has to be brought to their attention. And by knowing that medication may be the cause or a contributing factor to it, I think makes it much easier for people to confront the person who's affected and say, I heard about these compulsive disorders that occur in people with Parkinson's as a result of their medications. I know you're not doing anything wrong. I know that you don't feel that you're harming yourself or other people, but I think this is a medication side effect, and I think we should bring it to the attention of your doctor. And sometimes, I have to have a discussion with a patient, and they may disagree with me, where I say this is a problem, and they say it's not a problem. And if you cut down on my medicine, it's going to make me feel uncomfortable. And, I'll go to another doctor and I'll get the medicine from that doctor, and I won't tell them about this problem I have. That happens. And those patients are difficult to treat.
And
But I think it makes it easier to bring to attention somebody to say, I think this medicine is causing a problem that I see and that I understand you don't perceive this as a problem. We see this in other areas. Sometimes, people who hallucinate don't believe they're really hallucinations. They think there really is somebody living in their house because they see them at night, or that there are people coming into their house and stealing their money, and they just don't believe it. And then you just have to say, it's the medicine playing tricks on you. You're not, you don't have a mental illness. You have a drug side effect. And that usually makes it much easier for patients to tolerate, because it's as if they're not being blamed. They're not being asked to take responsibility that something has been done to them, not a bad, not on purpose to make them worse, but because something was being done and they experience the side effect, everybody's aware of the potential for side effects. And that usually makes it much easier to approach the patient and for the patient to tolerate this and not necessarily perceive it as criticism. You know, you are a bad person because you're hoarding, but you're doing this weird thing because of your medicine. It's Friedman's fault. It's Dr. Friedman's fault. We'll blame him and we can handle this problem. That's a much better way of dealing with it. It's easier for everybody.
But you brought up a good point, because you mentioned that some people, even if they recognize that it's a problem, they may not want it to stop because maybe they're not bothered by it, but removing the medication that's causing it could make them feel worse physically. So that's a difficult balance to kind of strike. And then how do care partners and other family members that are trying to navigate, you know, dealing with someone who's behaving, you know, oddly or doing things that might be bothersome to them, how do you suggest they manage those kind of things?
Oh, I think they need to confront the patient, you know, in a supportive way, saying, here's a problem. And I think that it's related to your Parkinson's disease treatment. And I think we should bring this to the attention of your neurologist and discuss it there.
So just kind of recapping some of the things that people have asked and some of the things that you've mentioned, you've talked about, you know, behaviors that could be hoarding, they can be eating strange things. Sweets are a big one. I had a couple people asking about sugar, you know, just an obsession with that, getting a sweet tooth and then eating, not just the weight gain, but just the inflammatory process that it can cause as being an issue. People who might be just fixated on reading email chains or carrying, you know, junk mail with them everywhere they go, but you're not using it for anything. So it can be a lot of different presentation. It's also can be multiple forms. So they cannot just have an obsession with gambling, but they could also be fixated on repetitive behaviors that are meaningless as well, correct?
Absolutely. Absolutely. That's exactly right. Yeah.
Awesome. Well, I think this has been extremely helpful to people. We have so many great questions. I know that we're not going to be able to get to all of them today, but it's something that is very important for us to all be aware of, because it can cause significant issues and it can cause a lot of stress. So one of the things that I wanted to highlight today before we close out is for the care partners and adult children that are on our program today. If you were not aware, we recently launched a new program on which we call a community called Getting Real Online. And some of you may have heard or been to one of our in-person programs called Getting Real. So it's kind of like that, but a little bit broader. And it's an online community where we provide some educational videos. And actually we have a whole series on impulse control disorders that Dr. Friedman filmed with us that breaks down each one of these individually. And that launched in April, and we're continuing to add new material, but we just launched today a new part of the platform, which has chat groups. And so you can join a different chat group. And for those of you who are struggling with some of these things, such as dealing with a loved one that has an impulse control disorder that they kind of like and they don't want to give up, or maybe resistance or in denial, which Dr. Friedman said can occur, there is a chat group for that. And so if you want to, Kelly, maybe drop the link for the registration on there, that is available. And then starting in June, we'll start having live discussion groups around dealing with some of these things, as well as some topic specific discussions around certain sessions that we have on the platform. So it's new, we're still building it, but I want to let the care partners know that we understand that some of these situations can be hard to navigate. And sometimes hearing other care partners share and adult children how they've gone through dealing with some of these things, what worked, can be very helpful. So we invite you guys to enjoy that. And I want to just thank Dr. Friedman for sharing. This has been such great information. We may need to bring you back for a recap again in the future so we can get through some of those questions that we didn't get to answer today. But I just want to thank you. And if everyone would give their wave of gratitude to Dr. Friedman for giving us such a great and insightful talk today. We thank you and hope you guys will join us again soon. Dr. Friedman, thank you so much.
Well, thank you for the invitation. I always enjoy speaking to Parkinson groups. So thank you very much for your attention. I appreciate it.
You're welcome. Everybody else, have a great rest of your Wednesday. Thank you.